Presentation is best will explore the critical components of fall management in nursing homes or post-acute care settings, with a focus on enhancing clinical excellence while adhering to regulatory compliance standards. And so I think that we chose this as a topic of discussion for effective fall prevention strategies, not only to safeguard resident health and well-being, but also when out doing pre-surveys or looking at 2567s. There seems to be a trend always with fall management. So we're going to go ahead and get started. Why is it important? So I think in most of the homes that we go to or that I have seen, they do a really good job of trying to implement different interventions, sometimes care planning and updating. I think the focus on the prevention end of things is what's lacking in most of the buildings that I've been to recently. And so typically most homes will use a fall Morris evaluation assessment or another evidence-based practice tool like that. And that's important because when somebody is being admitted into your home, you can establish what are the possibilities what are the interventions that you can put in place to attempt to prevent those falls up front. And why is that important? Because falls can lead to injuries, rehospitalizations, and even fatalities. And we all know that that happens in our homes. And so what can we do proactively that'll be measurable, that we will be able to significantly reduce the risk of falls and associated complications. This will have to promote better overall health, well-being for our residents, decrease our rehospitalization rates, and improve our friendly surveyors when they're coming in to look at our fall prevention. The intent of the regulation F689 is to ensure that nursing homes provide a safe environment for residents by implementing effective fall prevention measures, but it also covers multiple other areas. So it's not just about fall management, but today that's what we're focusing on. And F689 aims to promote resident safety, enhance quality of life, and reduce the incidence of falls and related injuries. Compliance with the regulations safeguards the health of residents, but also aligns with the overarching goal of delivering high quality person-centered care in nursing homes and post-acute care settings. Also, when the regulators are in our homes, they complete compliance audits and also make sure that what you're doing aligns with your policy and procedure. So you need to make sure that you're reviewing your policy and procedure, making sure that that's the practice that all of your staff are performing on a regular basis. We all know that the definition of a fall is defined as an unintentional change in position resulting in the person coming to rest on the ground floor or lower level. And sometimes that gets confusing, especially if you have residents who may like to be on the floor, or they may purposefully get on the floor. So I think while you guys are in your weekly meetings doing a root cause analysis, that would be helpful if you're identifying those types of residents so that you can care plan that this is what they're doing. It's a purposeful action for that resident in particular. Also, a fall-related injury is any physical harm that results from a fall. So fracture, laceration, head trauma, anything like that that occurs. And that can also lead to those harm tags G and higher, just depending on how the regulator is evaluating. Oops. Sorry about that. So how are you identifying residents at high risk of falling? And that is going back to the Morris Fall Scale or whatever evidence-based tool your company is using. And so comprehensive risk assessment is the foundation of ensuring a robust fall prevention program. That's the key, is prevention. So nursing home post-acute must proactively identify residents at high risk of falling and making sure that a thorough evaluation of individual factors is conducted. So what you want to look at is making sure that you're examining the resident's physical condition, cognitive condition, all of the environmental surroundings. Something else that I always think about is evaluating where they came from. So if they came from their home, how was their bedroom set up at home? How was their environment at home? What did they use to maneuver around the house? Do we have an effective look back at wherever they came from? Sometimes it's they've fallen at home and then they've gone to the hospital. So we also have to think and consider when implementing interventions proactively that sometimes in the hospital, we still have side rails and that sort of thing. And that's the stuff that we deal with in the post-acute care setting because families are, oh, that's helping them stay in the bed, or hey, we want the side rails that are put on, and we all know that that's very difficult in the post-acute care setting. So we want to examine that and make sure that our residents are safe in the bed without, if it's appropriate, those side rails or something like that. So we want to make sure that we're looking at how their house was set up, if that's where they came from, how the room was set up if they came from an assisted living, or if they recently transferred from the hospital, we need to consider all of those items that they have in the hospital that we don't particularly use in the post-acute care setting, and they're not really evidence-based practice. And feel free to put any questions that you guys have in the chat or anything like that, because Kaylee's monitoring that for me, and thanks again. So looking at, like we just discussed, the fall risk assessment, it's all about gathering that information, reviewing that medical history, and any previous fall incidents. And that occurs at admission. So if you gather a good baseline and understand, have they had previous fall incidents, what happened during the fall, any medical history that is related to falls. So something like a diagnosis of Parkinson's or many medications, as you guys know, also have side effects that could lead to falls, particularly blood pressure medications or if a resident's on opiates. So we need to take all of that into consideration. And also assessing their physical abilities. So why did they come and see us? Are they here for therapy and so they're feeling weaker than what they have been usually? Balance is very important, considering their muscle strength, as well as determining different areas of concern. So something I think we don't think about often is how about vision? So do we have their glasses? Have their glasses been, is it the correct prescription or is it an old pair that they had laying around? Do they need to see an eye doctor to help? Because sometimes if they don't have their glasses as well, that can lead to feeling dizzy or being off balance, and that can also lead to falls. Again, like I said before, inspecting the room and making sure that hazards are removed. And I think we need to compare that always to the history that we've received. So whether that's history from the resident or history from the family member that's joining them at admission, that's an important key component to look at, because the best predictor of future behaviors and conduct is going to be that past behavior. So they're always going to go back to what they know. And if you take that into consideration and put some things in place proactively, that may help to be able to prevent falls on the front end. Collaborating with the IDT as well and making sure that it's personalized fall prevention plan. I think a lot of times, especially if you get multiple admissions, you use templates or we're using what we need to meet the regulatory requirement. But if we're looking at a true fall prevention program, we need to make sure that it's individualized. Everyone's different. Everyone has a different diagnosis and could benefit from different interventions up front. We talked about already assessing the physical environment for fall hazards. That's crucial. We want to make sure that we're not tripping. Is the lighting good? Are we putting wet floor signs up? Are there any other safety concerns that could contribute to resident falls? In collaborating with the IDT team. So one of the key areas of collaboration, of course, is that weekly meeting. And I know some facilities review weights and wounds, but I always recommend also reviewing falls. I think that it's important, especially when you have residents that are just admitted and we're just getting to know them, that seems to be a time when they do have falls, or of course with change of condition when they're not feeling well, or they've developed a new infection in our home. That's also a time to keep a close watch on residents to help prevent falls as well. Some of the interventions for falls, looking at strength training, like I said previously, if they're coming in because they're weak, they were in the hospital, they were in assisted living, they've on a downward spiral, then we want to incorporate tailored exercises to improve muscle strength. And so getting your therapy on board, making sure you have a robust restorative program to help, all of those are key factors to maintain strength. And again, looking at the comprehensive risk assessment. What do we need to take from the risk assessment to ensure that we are examining the mobility of the residents, different medications that they're on, and like I said, various health conditions, such as Parkinson's and those sort of diagnoses. Assistive devices are very helpful. You want to get therapy involved and find out, were they using a walker at home and it hasn't been adjusted? Is it an appropriate cane, or do they need the four-legged side cane? Has therapy done an evaluation, or has nursing looked and assessed appropriately to make sure that the assistive devices make sense and it's not just an old walker or side cane that the resident was using previously and hadn't used before, but somehow just came over with the rest of the stuff from the assisted living, right? And then making sure that you not only talk to your staff about fall management, but getting the residents and the family involved and talking to them about fall risk and ways to prevent falls can be very helpful, especially when you're trying to build a rapport with a new resident in your facility. Also, looking at medication management. Sometimes if you find your resident has had multiple falls, you want to take medication management into consideration. Get the pharmacy consultant, get the provider on board to review the residents, look at all of the medications. Is it a side effect of one medication that's the problem? Is it the combination and concomitant side effects that are occurring because of two medications that have been prescribed? Do we need to look at the opiates? Are they too sedated? Any antidepressants that they have been on for a while, or maybe they just started something new and they seem to be a little off balance or something's happening. Sometimes it's just an adjustment in the dose that you need to look at. And sometimes it's looking at changing the whole medication. We also want to talk to the doctors and the other providers about optimizing medication doses. So we always want to keep our elders on the minimum amount of medication and dosage that's going to help with whatever the diagnosis is, whether that's an antidepressant or pain medication. We want to do that to be able to decrease the amount of side effects and ensure that we're not causing more dizziness, drowsiness that could possibly contribute to
No, I have it here.
making medication adjustments and providing education for all of the staff can be helpful as well. Promoting mobility and functional independence. So that's going back to our therapy programs and looking at our therapy programs. Are we offering therapeutic exercises? And that doesn't mean that we just need to have one resident. Sometimes we can do a group of 3 or 4, and we can develop programs to help increase the strength, promote flexibility and balance, and maintain functional abilities for our residents. And also, like I said before, having a robust restorative care program is critical so that some of the residents, especially those that we have maybe in memory care or maybe those that are suffering from dementia, can relearn some of the activities of daily living and regain some of their independence. Mobility monitoring, and one of the other key components that I always promote that I think is effective. Not sure how many of your facilities are utilizing this, but purposeful rounding for fall prevention is very helpful, especially when they know that they're going to see a staff member coming by the room. Hey, is there anything that you need? Even if you're not doing the 4Ps or anything like that. But I think moving towards a standard of having CNAs go into the rooms, or maybe the activities going into the room, and then making sure that we keep it on a schedule that the residents know, hey, I'm not going to just try to get out of bed by myself because my call light's been ringing, but I know that Carmen's going to come into my room, or Kaylee's going to come into my room next, because we make it a practice and a habit. And so the residents know that we're coming around hourly and just seeing what they need, or asking or answering call lights, asking them what they need. Much of the assistive devices and adaptive equipment, like I talked about, can be taken into consideration through our therapy assessments: walkers, canes, wheelchairs, grab bars. What we really need to look at the root cause after a fall happens, right? And so sometimes looking at that walker, like we talked about, making sure that it was assessed properly, especially with our new admissions, making sure that the height is adjusted appropriately, making sure that our staff know, hey, it looks like they're struggling a little bit to use their walker. I need to reach out to whoever takes care of that in my facility and let them know so that it can be adjusted. Those devices are critical to make sure that you're maximizing the effectiveness of why they're actually using it. And then, of course, going back to staff training, making sure that you have not only training what to do after a fall occurs. I think we do a really good job with that. But I think the initial training of what do we do when our residents get there, and how do we assess what's happened in the past. Comprehensive fall prevention education for all new staff is very important. I remember early on in my career, I couldn't figure out why they said, hey, every time someone falls, you've got to have an intervention. I'm like, what? Why? It doesn't make sense. And so I think a lot of times, if we get to the why, you're going to find that nursing staff are more likely to say, oh, now I remember, this is what I have to do because this person fell. So it's not just, let's get them off, let's do an assessment and get them off the floor. It's also looking around the room. How did they get there? What happened? And making sure, even though it may not be a complete root cause analysis, but just getting them in that mindset so that we can have an immediate intervention. A lot of times when reviewing incident reports, that's one of the things that we look at. And most of the times, the immediate intervention is either not documented or it just didn't occur. And new intervention isn't added until, of course, the IDT meets during the week. You also need to look and make sure that your policies and procedures are updated, and making sure that your practice in the facility is also following the policy and procedure. So making sure that the incident reporting protocols are clear for staff. How do you fill out the information and risk management in PCC? If you're using PCC, what information goes in what box? It needs to include details on the time. For people in the state of Colorado, the RN assessment is constantly looked at during survey. And so it needs to be very clear that before the resident is moved from the floor, that RN did the assessment, and what did that assessment look like, making sure that it's safe to move the resident from the floor. We need to make sure that they know where to put details on the location, the time, what was going on before and after the fall occurred. As much documentation as possible, so that way when the IDT does review, all the information is there and you're not having to make phone calls to somebody who may be off or somebody who had worked a night shift. After the fall occurs, the key is going to be a root cause analysis to make sure it makes sense. So if somebody fell and they slid from their wheelchair, and it's because their wheelchair is slippery, we're not going to put a toileting plan in place. And sometimes we see that when we're doing, somebody's not on mute. Again, looking at a root cause analysis of resident with falls is critical. So gathering up all the information, taking a good history and assessment, making sure that we know all the contributing factors, what happened before, doing a timeline of interventions that have been in place are some of the things that I recommend. Identifying contributing factors, like I said, pinpointing underlying causes. Is it medication? Is it a change of condition? Was there environmental hazards? Do we not have good footwear for somebody to use, or was the footwear not on? And also making sure that we're developing corrective actions, an action plan, or interventions that make sense. So I just use a simple example of sliding out of the wheelchair and then somebody implementing a toileting plan because they said, oh, I was trying to get to the bathroom, but is that actually why they fell? Or is it because that cushion was slippery and it slipped down to the floor? So when we're looking at making sure we have interventions in place, we need to make sure that it makes sense based on our root cause analysis. And of course, developing individualized care plans. So although it's easy to use some of those templates and that'll help things get started, in order to have a robust fall management program, we really need to have that personalized assessment. And like I said, it all starts at admission when we're looking at the history of the resident and the fall history. Making sure that we conduct a thorough evaluation and that all fall risk factors are identified, and not just identified, but what did we do with that information, right? So we need to make sure if we're identifying a risk that we have a solution to the risk. And then also a collaborative approach. So if the families bring them in admission, we need to make sure that we're involving the resident, the family, and of course the interdisciplinary team. A lot of times we don't think about activities, but sometimes if they're in their room by themselves, sometimes activities can help, and it's a really good idea to get them involved. And making sure that we tailor the interventions to the root cause, like we just discussed. Interdisciplinary approach for fall management includes nursing, so that's the fall risk assessment, care planning, intervention implementation, and then making sure we go back and review. So maybe we thought we had a good root cause analysis and we implemented them in a wheelchair, but actually it wasn't effective. So we need to go back to the drawing board and making sure that we change it and update the care plan. And that's okay to do. Maybe we thought it was going to work, but after a couple of times they're still sliding out and we found out it was for a different reason. That's okay. We just need to make sure during our review process that it's robust and that we're making sure that we change the intervention if it's not effective. Involving physical therapy, like I said, or restorative for strengthening, exercise, balance, making sure that if they wear glasses, they have glasses, or maybe they've never worn glasses because they just haven't been to the eye doctor, right? So making sure that their vision is corrected when they're up and walking or getting around in their room. Looking at occupational therapy for environmental assessments, adaptive equipment, and making sure that that equipment is in good working condition. And then, of course, pharmacy with the medication review. And another key area, management of polypharmacy. Sometimes it's not the side effect of the medication, but because of two medications that are being used, we have more side effects. So that would require more monitoring as well. So we need to make sure that we are limiting as many medications as we possibly can. Engaging residents and families in fall prevention includes making sure that they're aware of what the risks are. A lot of times families are there on a daily basis. And so what do they need to know about falls and what do they need to understand about prevention measures that the facility has identified for their loved one? And encouraging participation and letting them know that this is key to making sure that they're safe as well. So making sure you have prevention activities that everybody knows about it. Kind of everybody's talking about fall management all the time, 24/7, because it happens on all shifts. It happens on weekend shifts, day shift, night shift, constantly. So it should be something that's communicated all the time and not just when somebody falls. Making sure that you have those collaborative care plans, like I said, and transparent and open communication. What happened? Incident tracking is very important. Like I said, making sure that you have a complete and thorough document that describes exactly what happened with the incident, especially when somebody was injured. You want to make sure you have all the details of it, the fact that the RN had assessed prior to getting up from the floor, and that you're able to identify patterns if this is more than the first fall. Sometimes I would recommend utilizing a timeline. If you have someone that's fallen 10 times in the past 3 months, utilize a timeline. Sometimes it helps just to write it out and see what was the intervention, how did they fall, looking at the root cause, what else do we need to do. And also, like I said, making sure the evaluation, the effectiveness of the intervention that was put in place is actually working. So that'll help to decrease our fall rates and improve our QAPI numbers as well. Continuous monitoring and evaluation of all fall prevention strategies is essential to ensuring effectiveness. And then we want to make sure that we're driving the ongoing quality improvement process by systemically tracking incident, measuring outcomes, and using that information to refine our process. So we can look at a timeline for people who have had multiple falls. That's part of our continuous quality improvement process, and we can help with that as well. It's data driven, making sure that you have interdisciplinary collaboration, and then a rapid cycle testing. So implementing and quickly testing new fall prevention strategies so that you can change them if necessary. Making sure all documentation related to incidents and interventions is in place and complete, and ensuring ongoing staff education and competency validation. So it's not just enough to deliver the education, deliver the information about the policy and procedure. We also need to make sure that they are competent, they can speak to the policy, and they know what to do when somebody falls. Annual competency assessments are great, but clinical excellence every 3 months and constant talk about fall prevention is going to help to develop a robust program. Incorporating best practices with a comprehensive approach, evidence-based interventions such as purposeful rounding tools, looking at your continuous quality improvement and interdisciplinary collaboration is going to help with that robust fall program. And of course, making sure you benchmark your fall rates and outcomes. We kind of talked about this already, balancing fall prevention and resident autonomy. So least restrictive interventions, education, and a personalized approach. And most important, making sure that we give the resident a choice and empower the residents to make their decisions about their own care. That helps to promote independence and dignity as well. We kind of talked about communication already, and I know I'm running out of time, so I want to get through this. And this will all help with preparing for regulatory inspections and surveys. Fostering a culture that happens all the time of fall prevention will lead to a successful fall prevention program, decrease the rehospitalization rates, and definitely help to engage all stakeholders and sustain continuous quality improvement. I just want to thank everybody for joining us for our first clinical corner, clinical compliance. Our next